Our next presentation is entitled Prospective Multicenter Validation of the Canadian Syncope Risk Score, presented by Venkatesh Thiruganasambandamoorthy of University of Ottawa. Welcome.
Thank you. Thank you very much. And the study is entitled Prospective Multicenter Validation of the Canadian Syncope Risk Score. You can tweet us at Team Venk if you are a tweeter. Thanks to all the co-investigators. This was a collaborative effort at 8 centers across Canada and was funded by the Canadian Arrhythmia Network and as well as Heart and Stroke Foundation of Canada. We don't have any conflicts to declare. As you know, syncope is a common problem. 1% of all ED visits are because of syncope. 7 to 10% of patients have some serious underlying conditions that would have contributed to the syncope. Half of these conditions will not be identified during the initial ED evaluation. So that brings in the use of risk tools, and the risk tools, there is none of them to robustly risk stratify these patients. Hence, we embarked on this research program to risk stratify ED syncope, and as a first step, we derived the Canadian Syncope Risk Score. It was a prospective study that was conducted to identify patients who are at risk for serious outcomes after emergency department disposition within 30 days. The risk score itself consisted of 9 predictive variables, 3 separate domains. Each of the predictive variables gives you a score. You add the score for the given patient and then risk stratify them as either very low risk, if you have a score of -3 or -2, low risk as -1 and 0, 1 to 3 is a medium risk, 4 and 5 are high risk, above 6 is very high risk. So the objective of this study is to validate the Canadian Syncope Risk Score in a new population. It was a prospective study conducted from March 2014 to October 2017 at 8 large tertiary care EDs. And we included adults with syncope who presented within 24 hours. These are the standard exclusion criteria for all large-scale syncope studies that are done across Canada, which excludes non-syncope patients, seizure patients, if you have a head injury first, or if you have major trauma that required hospitalization. In Canada, verbal consent was good enough for inclusion in the study. We collected demographics and medical history, and we collected the 9 predictive variables for the Canadian Syncope Risk Score. 30-day serious outcomes included death, important arrhythmias that will require treatment, non-arrhythmic conditions such as myocardial infarction, serious structural heart disease, or aortic dissection, non-cardiac conditions such as PE, hemorrhages, and other important conditions that we need to detect them in the emergency department so that patients do not suffer any morbidity, such as ectopic pregnancy, sepsis, or any procedural interventions to treat syncope, such as pacemaker insertions. Outcomes were assessed using medical records and a 30-day telephone follow-up, review of records at all the local hospitals linking to the provincial healthcare systems database. We collected if serious outcomes did occur, the time and place of the serious outcome. We analyzed the classification performance of our risk score, the discrimination and the calibration characteristics. Additionally, we also combined the data to come up with some more clinical recommendations. The results of the study are, we screened 12,682 patients. More than 7,300 patients were excluded because they were not syncope. Of the potential eligible patients, 73% of all patients were enrolled into the study. 5% were lost to follow-up. 3.6% of patients had an obvious outcome in the emergency department. We are excluded from the study. We included 2,911 patients in the final cohort. Mean age, 53.4, wide range of patients, half of them females, 2/3 arrived by ambulance, 1/3 had hypertension, about 11% with diabetes, coronary artery disease, and a small proportion with atrial fibrillation and congestive heart failure. Majority of them had some kind of testing done, and our hospitalization rates are 9%. It's not a typo, it's 9%. Our total serious outcomes were 109 patients suffered outcomes, 3.7%, and 2.4% as inpatients and 1.4% after ED disposition. So the outcomes included about 12 deaths, a large proportion of arrhythmias, some non-arrhythmic conditions such as serious structural heart disease and acute coronary syndrome, some PEs, and significant hemorrhages. So in the study cohort, 42% of patients were very low risk, 33% were low risk, 18% medium risk, and a smaller proportion at high and very high risks. How did the score perform? If you're very low risk, your probability of 30-day outcome is 0.2%. If you're low, it's 0.8%. If you're medium, it is 8.5, and it increases all the way to 60. So there was an excellent classification ability for the Canadian Syncope risk score. If you look at very specific outcomes, such as any cause death or death due to unknown cause, the risk ranged from 0% to 10% or 12%, so excellent ability to classify deaths. Any arrhythmias ranged from 0.2 to 38% as you go up the risk stratification system. Ventricular arrhythmias from 0 to 8%. Non-arrhythmic conditions, 0.1% to 12%. So the overall ability for the score to discriminate patients with and without outcomes was also excellent, with an area under the curve of 0.9, which was comparable to the derivation phase. This is a calibration plot. Expected risk on the x-axis. On the y-axis is observed risk. The dotted line right diagonally going across in the middle is the ideal line where you want your study line to be. Our study line is pretty much ideal with all the patients. Their observed risk was proportionate to the expected risk as per the score. So how can you apply this? After you have a thorough history and a physical examination, ECG, and a focused investigation for the patient that will be appropriate based on the clinical setting, if you don't find anything serious, you can apply the Canadian Syncope risk score, and it will tell you what the risk of your patient is. If you're very low, you're at 0.2%, you can be discharged immediately from the emergency department. And in Canada, we will also discharge 0.8%, the very low risk, the low risk patients, because it's less than 1%. We'll discharge them from the emergency department. If you have a very low risk threshold, your sensitivity will be 97.2. There are only 3 outcomes in this group, so there is a wide confidence interval. The negative predictive value is 99.8%. If you choose the low risk, it's about a high 90% sensitivity with, again, the negative predictive value of 99.5%. So, non-low risk patients, what should we do? The high risk and the very high risk, obviously they have a high proportion of outcomes, 21 and 60%. I think these patients need to be referred for hospitalization. The positive likelihood ratio is 12.4 for these patients. What do we have left out? The challenges now remain are that how long do we need to hospitalize the high risk and the very high risk patients, and how do we deal with the medium risk patients? For that, we combined the 2 cohorts and did a time to event analysis. These are the risks of non-arrhythmic outcomes in the high-risk patients, which include the high and the very high risk. So as you see, the risk is very high at day 0. On the x-axis is the number of days after the index visit, and on the y-axis is the probability of a serious outcome. So you have a 30 to 35% risk on day 1 that slowly decreases. It's reasonable to hospitalize these patients for about 3 to 4 days. For medium and high-risk patients, these are the arrhythmias that happen at various times. The red bars are the high-risk patients, and the blue bars are the medium-risk patients. On the y-axis is the probability of arrhythmic outcomes and the number of days after the ED visit. The risk is highest on day 0, and it slowly decreases. You have about a 0.5 to 1% risk of an arrhythmia in these moderate and high-risk patients every single day until day 15. After that, it drops off. It is reasonable to do cardiac monitoring on these patients as an outpatient if they are discharged home. We need a 15-day cardiac monitoring for these patients in order to detect underlying arrhythmias for these patients. If you look at the medium risk patients, they have an 8% risk of having some serious outcomes. 6% of them are arrhythmias. Majority of them are atrial arrhythmias. So there can be a shared decision-making model in order to discharge them home with cardiac monitoring. So in summary, after evaluation, low and very low risk patients can be discharged home. Medium risk patients, you can do a shared decision-making process with the patient. High and very high risk patients, hospitalization for a short time. And the medium, high, and very high risk patients should have cardiac monitoring for 2 weeks. limitations: 1/4 of eligible patients were not enrolled, up to 5% of patients were lost to follow-up, 3% did not have an ECG performed. A good proportion of low and very low risk patients did not have troponin performed, and we did impute them as normal. And the ED diagnosis may vary among patients. It's ready to apply to practice. It will help you to predict short-term outcomes and make disposition decisions. It should improve the hospitalization practices. It should improve arrhythmia detection by outpatient cardiac monitoring, and it should improve patient safety and reduce healthcare resource utilization. I thank the co-investigators and the people who are involved in the study, the Ottawa team, the team at home, and thank you.
Questions?
Thank you, Mark Courtney from Northwestern. Very brief question. Do you have any comment on inter-observer agreement for the term that was prone to vasovagal syncope, or how would you comment that that was or should be operationalized either in the research or in practice?
See, the definition of vasovagal syncope is that if you are in a warm, crowded place, if you are prolonged standing, if you have fear, emotion such as anxiety or extreme pain before. That has been published in the European Society of Cardiology guidelines, and the inter-observer agreement for them is about 0.54. There is a recent publication in the Academic Emergency Medicine on the prognosis of your ED diagnosis. The part of this data was all published in there. The vasovagal syncope and the cardiac syncope, the kappa values were about 0.65 to 0.68. The orthostatic hypotension agreement was about 0.5, and the one for I don't know category was 0.48.
It's Will Moyer from the University of Michigan. As a sort of follow-up question to that, why do you keep putting in those subjective things into your decision rules, like the it sounds vasovagal? The rule would be so much better if, I know that Canada and America have been pretty friendly since the War of 1812, but it seems like the clinicians are actually using all those other factors. They're all correlated. They're like, sounds vasovagal. Everybody who sounds vasovagal is good. Your rule basically reduces to, sounds vasovagal, go home. So couldn't you use your data to, I guess, for good and not subjective evil, so that we could use something that people wouldn't have as much subjectivity in applying? I'm happy to reanalyze your data set and derive the rule that way. What do you think?
So we have the PE risk score and the DVT risk score, and we have the heart score. Every time you incorporated the good ability of taking a history and a physical examination, it has performed really well. That's one. Second thing, you have a patient who saw blood and had a vasovagal syncope, but has got some cardiac problems, and you want to know what the risk is. You know very well it's vasovagal syncope, but you have some comorbidities that is existing in this patient. You apply the risk score. You say that it's vasovagal syncope, and then you come up with a score. It will tell you some information about what the probability is. When you truly don't know, you just do not do a -2 or a +2 for the score, and then you're neither too much underestimating or overestimating the risk. So bottom line, it's very important to use the clinical skills. If you truly don't know, you don't score those variables so that you don't underestimate or overestimate. There are going to be some instances where it's going to be very clear. Still, you can use the rough score. When it is not clear, then you just don't score those points. You will get right in the middle of 0 where the scores are for these two. And the rest of the factors will depend. Even if you remove the 2 scores, we are going to publish that because we are waiting for more information. So now we will be able to publish after removing the 2 scores. But I strongly suggest to do the history and physical examination.
Thank you very much, Dr. Thiruganasambandamoorthy.